Today, on our inaugural Painful Conversations podcast brought to you by the Pain Society of Alberta, I am thrilled to have past president of the Pain Society of Alberta, Dr. Robert Tanguay, esteemed psychiatrist. He is the co-chair for the Alberta Pain Strategy. He is the co-founder of the Rapid Access Addiction Medical Clinic, where he practices clinically. He has also been a member of the Alberta Psychedelic Legislative Committee. He has received the Early Career Leadership Award from the Royal College of Physicians and Surgeons and the Queen Elizabeth II Platinum Jubilee Medal, among a million other credentials. We are thrilled to have him today to talk about psychedelics and chronic pain. I am so excited to be here with Dr. Rob Tanguay on our inaugural podcast called Painful Conversations, part of the Pain Society of Alberta. And today we are going to be talking about psychedelics and their use for treatment in pain, among other things. So, Rob, I'm so happy to have you here. Tell me, what's the biggest myth that people have about psychedelics?
Oh, well, thank you for having me. I don't know. I think there's so much myth, whether it's they're illicit drugs to they're the newest panacea to treat everything and anything like cannabis. I think both of those answers are false, or, as we usually see in life, radical or extreme. I would say those are probably the two biggest myths.
So, how did you get into psychedelics, coming from psychiatry and having, I'm sure, worked in some pretty traditional settings to being involved with something so novel?
So just to be clear, I'm not that involved in psychedelics. I think that there was a lot of curiosity, and I was involved in a clinic that was opening that the media kind of pulled it towards being a psychedelic clinic, which it's not. But at the end of the day, I sat on the legislative committee and trying to put together the correct safety mechanisms to protect patients, as there's been a phenomenal amount of data and information, even charges on the harms. And so while I think every psychiatrist is pretty fascinated about a new tool in our toolbox, many of us are still data driven and going in with it eyes wide.
And I mean, knowledge is power.
Yeah, I think so. Knowledge supported by good evidence-based data and peer-reviewed literature.
Yeah. So give us a little bit of a lowdown on what that looks like in terms of the evidence-based literature around psychedelics.
Yeah, I mean, there's good data coming out of MAPS. And I think that's kind of the important thing, is that there's 2 phase 3 clinical trials. These were randomized clinical trials, multi-site, large. I mean, in comparison to some med trials, maybe quite small, but still significant. And in the MAPS trials, they showed significant benefit of MDMA in the treatment of PTSD with the use of psychotherapy. And then there's quite a few trials looking at psilocybin, many phase 2 clinical trials, and how psilocybin with psychotherapy is a good treatment for treatment-resistant depression. It hasn't moved into published phase 3 clinical trials. There are some out there. So we're definitely getting them.
So when it comes to chronic pain or even acute pain, has there been a lot of research looking into that side of it, or can there be an impact?
Well, that gets really tricky too. I think that when we look at that, so chronic pain, so do psychedelics treat pain? There's a question people can ask. We don't have very much data to say yes. Do psychedelics treat the mental health that is often comorbid with people who live with persistent and chronic pain? Very likely it does. Does the treatment of mental health comorbidities such as trauma or depression or anxiety disorders improve outcomes in pain? We absolutely know the data is clear
100%.
on that. So invariably, by treating them with an effective treatment, treating mental illness, comorbid in those with chronic and persistent pain, will in turn reduce the perception of pain. More so, will improve functionality and quality of life.
Which is so incredibly important.
Agreed.
Because it's great to have something that might work, but what's the outcome? What's the consequence? And if you can get more out of your life, I mean, at the end of the day, that's what people should.
Yeah, no, I agree with that. One of the problems, though, is that as we know in Canada, access to tertiary chronic pain centers is extremely poor. Access to any sort of pain treatment is extremely poor. Most primary care physicians, your family doctor, often have very little training in the treatment of chronic pain. So that leads a lot of people sitting on wait lists not having access to good care. So when we start talking about experimental or possibly fourth line or third line treatments, that's great. But in good, healthcare policy, we should be focusing on why people don't have access to first line treatment. And right now, people don't in Canada, no matter where you are, have rapid access to good treatment for chronic pain.
And just because that's the way it's been for so long, doesn't mean that that's the way it should be. If we know that the first line of treatment works and it's effective, except it's not available, then why wouldn't that be what we're trying to target?
Yeah, I agree. And I guess so what that leads to is physicians and other healthcare providers hoping for a magic pill. And so the magic pill at one time was oxycodone. The magic pill now, then the magic pill was rolled up in a joint with cannabis. And then now the magic pill is starting to be pushed upon as now it's psychedelics. There is no magic pill. But if I'm a psychologist working in my private practice and I have a load of individuals who are struggling with mental illness and chronic pain, and there happens to be a medication that I can actually provide that will invariably immediately help that person, well, of course I'm excited, versus waiting for years to get into an interdisciplinary chronic pain program. So, from the ground level, people are excited and screaming for this, but it's because they're so invariably burnt out from waiting that we almost have this elephant syndrome that, we've had a chain on our leg for so long and not having access, when in reality, we should be advocating for more access and breaking the chain, which has really just become dental floss. But we believe we can't do anything else. And if we can't do anything else, we must go for psychedelics.
Yeah. So for those that will respond to psychedelics, who is it meant for? Who's the target population if it's something that's available to them?
Well, at this point, I believe there's only been one patient, and I think it was touted on social media. So I don't even know if that's necessarily true. I don't know if anyone in Canada has ever been treated for chronic pain with psychedelics.
Yeah.
So that's probably not the target population. Somebody with treatment-resistant depression. So that means they have failed multiple medications and failed evidence-based psychotherapeutic treatment. So I failed 2 antidepressants. I failed a first-line adjunct medication. I failed a second-line treatment. And I failed cognitive behavioral therapy provided by a psychologist or maybe online of some sort. Then maybe that person, depending on the level of suffering and dysfunction, may be approved under the Health Canada Special Access Program, at which point that person then has to pay for the psychotherapy, which is, 20, 30 hours of psychotherapy, plus pay for the psilocybin treatment. So you're looking at, 10 to 20, MAPS suggested as much as $24,000 worth of therapy and medication costs. So a very finite amount of people.
And it's not just going to be as simple as going out and microdosing.
Oh, there's no data that microdosing is going to help people with treatment-resistant depression. There's no data that microdosing is going to help people with chronic pain. Microdosing is how the biopharmaceutical industry is looking at how are we actually going to make money on this. So the data suggests 2 macro doses of psilocybin is highly effective in treating treatment-resistant depression. Well, there's not a lot of money if all we're doing is treating people twice. Yeah. But if we can replace their antidepressant, no more Prozac, take the mushroom, take it daily, and we will sell it to you. That's a multi-billion-dollar business. So we just don't have any data to suggest that's going to work.
So is this similar to what happened with cannabis in the last 10 or so years?
Well, I think that was one of the reasons that Alberta put together legislation was to prevent it from becoming a panacea. In Calgary, we used to have a clinic that you would walk into for cannabis, and it would say treats gout, treats ADHD, treats arthritis, treats liver disease,
PTSD,
treats
anxiety,
everything, right?
100%.
Everything. It was actually all on the big wall, like all the disorders it treats. And really, there was absolutely no literature to support that. So the goal is to try to prevent, the privatization and profiteering that could rapidly occur in this spot, that did occur in cannabis, that then actually set us back significantly in getting good research and good data and good outcomes, because there's no doubt for some people it definitely helps. We just don't know who, we don't know what doses, we don't know how much THC versus CBD versus CBG versus who knows what other molecule is in there. We don't know if smoking versus inhaling versus edibles, what is better, and really trying to get any data out of research from people who have never used it for chronic illnesses is also extremely hard to recruit those people because it's available everywhere for anyone. So when we legalized it for medical purposes, it was never really legalized for medical purposes. It was just legalized, and doctors and clinics made a ton of money prescribing it for no real indication. And then it became commercialized under legalization. Certainly that's the fear in this. And that seems to be the path, except everything under psychedelics looks to be under randomized controlled trials. So the 2 main ones, MDMA with psychotherapy for PTSD, psilocybin with psychotherapy for treatment-resistant depression.
So in terms of psychedelics, we've talked about who it might help. Who is really not the audience? Like, what are the contraindications, the people that they really shouldn't even kind of consider this?
Yeah, so you definitely need to be medically assessed before. There's risks for cardiac functions. The risks are not very high, but they're there. Certainly, there's risks for individuals who have psychotic disorders or a background of psychosis. So people are hearing voices or struggling with their thoughts or struggling with what's real and not real, schizophrenia and other disorders. Probably not the right route, although there's actually some research underway in that area. But right now, no. And I guess, unfortunately, as is the reality in Canada anyways, for most psychotherapy and physiotherapy, people with no money, because it's not free.
So what about people who potentially have a history of addiction?
Well, I think, again, under the guise of a good treatment algorithm, and there is some data, very minimal. We're doing a review right now, and it's funny. Some of the authors are like, "Oh, here's a great study. It helped with detox from alcohol." It's like, that's not treatment for addiction. That doesn't count. You can't call that treatment. Oh, it helped with withdrawal symptoms and opioids. That's not treatment for addiction. You can't call. So we actually had to whittle out a lot of papers, which left us with almost nothing. There seems to be really good signals and some data coming out for cigarettes, nicotine cessation, and psilocybin.
Okay.
So interesting for that. There are some small trials with some significant biases in the trials for alcohol. So we're starting to see that it may fit in there. But again, if we look at addiction, most people who suffer from addiction, similar to chronic pain, are also struggling with mental illness if we're talking about an indication, right? So if we're talking about an indication for chronic pain, it's because there's a mental illness. If we're talking about an indication for addiction, it's probably because there's a mental illness.
And the message I'm hearing is that it is not as simple as just taking a psychedelic and letting it do its thing. It's still this integrated care approach.
Oh, 100%. Otherwise, we could all just take mushrooms and sit around a campfire and we'd all be cured of all of our mental illness, and the world would be a better place.
And if that were true, they probably would have figured that out in the 60s.
Yeah, probably, right? Maybe they actually were happier in the 60s, and maybe that was part of it. And maybe we just need to put it in the water with the fluoride and a little bit of Suboxone, and the world will be a better place.
Easy peasy, and access for everyone.
If only it was that easy, right? Yes. The answer is yes. We need to honestly realize that it has to be in combination with psychotherapy, and that's what all the data says. And unfortunately, that's what the FDA is reviewing.
So when it comes to psychedelics, if there's a few key things that whether it's a psychologist, a family physician, a physiotherapist, or a person living with pain, if there were a few things that you really wanted them to know, what would it be?
Well, it's going to be expensive if you're going to go down that road. If you were just to order this stuff online, which you can, which maybe I shouldn't tell you that, but anyways, it's illegal. Remember that. And there's absolutely no data that sitting at home eating mushrooms is going to help. And it could be dangerous. Some people have very bad so-called trips. And being at home alone, taking a bunch of mushrooms, may be a very scary, may induce significant anxiety and panic, may create a psychosis, may not be a good idea. At the same time, under the guise of professionals, so psychologists who've been trained in this area, psychiatrists who's actually diagnosed it appropriately, your pain medicine team approving and agreeing that this should be done, it may be beneficial.
Let me just take a minute to say thank you to the Being Human Club, a trauma-informed mental health community located in downtown Calgary, for letting us use their space. Thank you so much, BHC. Also, to let you know that we have an amazing conference coming in October of 2024, the 17th to the 19th in Banff at the Rimrock Hotel. Hope to see you there, and we will focus on excellence in pain education. So, knowing that you've had a long history in so many areas and so many successes, you have done work in chronic pain, and this is about painful conversations. What would you want to change in how people talk about chronic pain?
I think so much. I think, I think we need to shift the understanding that chronic pain isn't simply treatable with a medication. That it takes a true interdisciplinary approach for those who end up in tertiary care and really are struggling to cope. That there is a significant psychological implication to pain, which makes sense, right? Like imagine you have an injury or even more difficult, an insidious onset of some pain that comes out of nowhere that is horrific. Of course, that's going to affect your mental health. If it slips into a major depressive disorder, that has to be treated because the more depressed you get, the more the pain becomes prominent in your life, the more dysfunction, the more painful the pain becomes. So that's an important thing. Physical aspects, like, so many people get stuck in the spiral of, oh, it hurts too much to move, so I won't move. Then that leads to atrophy of their muscles, and that leads to a decompensated state, which increases your pain. So, we need rapid access and rapid education for so many people. But I guess the most important is that pain is a medical condition that should be accessible for treatment. And we're not there yet. I think in Alberta, we've made some great strides with the new Alberta Virtual Pain Program, and the first phase of that being the Alberta Virtual Chronic Pain, which is available to every Albertan. You can look it up. You can start treatment right away. There's psychologists, kinesiologists, physiotherapists. It's an absolutely fantastic program. It's going to shift into phase 2 and phase 3, which will include deprescribing, so helping people get off of all the meds that they get stuck on, especially when they find out those meds may be actually making everything worse. And transitional pains, so supporting people post-surgery. The amount of medications and pain and what happens and what are my expectations of surgery. So these next pieces are moving into virtual programming available for every single Albertan. So very exciting, but it's great for Albertans. What if I live in Manitoba or PEI or, Northern Ontario? That may not at all in any way be available.
So moving away from psychedelics, with something that I almost feel like it's psychedelic adjacent because it often gets lumped into the same conversation, ketamine.
Yeah, I think ketamine is a different beast altogether. It gets lumped into the psychedelics, but that's the profiteering part of it, right? So we're gonna open a psychedelic clinic and treat everyone with ketamine because nothing else is legal and nothing else is accessible. So it's truly just a ketamine clinic. So ketamine has analgesic properties. It truly, and we know this post-surgical, that's what it's used for. It was an anesthetic, a dissociative anesthetic used during surgery, and reduced pain, reduced opioid and other medication usage for individuals after surgery and during surgery. It just so happens that a very smart anesthesiologist started realizing his veteran patients were feeling better waking up from surgery, and nobody feels better waking up after surgery. And it didn't make any sense why these people are waking up feeling better. So then, started digging into the data, like noticing, hey, there's a signal here. We're going to dig into that data. That data then showed people with depression, one treatment with ketamine, which just happened to be during their surgery, lifted their depression. So it's a powerful antidepressant, probably the most powerful antidepressant we have. In fact, it's got level 1 evidence for the treatment of treatment-resistant depression and the treatment of depression. One dose of IV ketamine has level 1 evidence. It's unfortunately shifted down to a third-line treatment because of accessibility and costs and the requirements for IV treatment and anesthesiology. So, but outside of that, our CANMET guidelines clearly showed, level 1 evidence for it. It absolutely works. So here's a fascinating thing now in chronic pain. We have a medication that is powerful antidepressant. It turns off ruminative thoughts. It turns off intrusive thoughts. It reduces suicidality. It turns off those intrusive suicidal thinking. It is an analgesic and reduces pain at a physiological level, and it treats your mental health. Pretty cool. So is it the answer to everyone? No. I've seen a lot of, when I was doing my fellowship, I saw a lot of ketamine going out the doors, and a lot of people misusing it, selling it, trading it, giving it to others to try. It's dangerous. Matthew Perry died from it. I mean, it's just not a simple inert drug. It's an anesthetic.
It's powerful.
It's very powerful, but under the right direction. We see more and more people on sublingual ketamine for mental illness, prescribed by psychiatrists with take-home doses under very strict parameters to prevent diversion and misuse. And a lot of people have found it to be a game changer in their lives.
And really, when you think about, as you said, stopping the ruminative thoughts, having an analgesic, stopping the suicidal thinking, imagine what somebody who's living with pain can do when some of those pieces are controlled in terms of reconnecting with all the different parts of their life.
Pretty powerful.
I mean, it speaks volumes to the kind of jumpstart that can
absolutely
be.
And that's how I kind of look at it, right? Like, if you can stabilize someone really rapidly with this medication and then get them through the therapeutic processes, the physiotherapy, build an exercise regime, build an exercise regime for the brain, right? Some resiliency and some mental health tools to build up your skills while stabilized on ketamine. Nobody knows long-term if ketamine has great long-term effects, right? Look, I mean, most opioids are phenomenal acute, not so phenomenal long-term. So is that the same in this case? We don't know. We don't have long-term data in this. So I really look at it like every tertiary pain clinic should have ketamine as a part of their treatment protocol. And many don't. So now you wait forever to get into a tertiary pain clinic that actually doesn't have all the tools needed to treat you. It's just unbelievable.
Well, and ultimately, when you have that, what I'm taking away from this is, one, that it's not going to be one magic pill. Whether it's a psychedelic, whether it's ketamine, it's never going to be one thing. But also, you can't just stop. You can't just say, well, we've done the ketamine, so now we're good. It might be the ketamine, but then the exercise, but then the education, but then the function, the psychology. It has to be an ongoing process. It's not going to be a simple solution that we can just say, we fixed it, tie a bow on it, and then we're finished.
No, that's fair.
It's going to be a chronic condition that needs chronic management, but is also hopeful.
Yeah.
Thank you so much for this. This was enlightening. I have no doubt that there are people out there practicing with people living with pain, as well as the people living with pain themselves, that know a lot more now than they did before this started.
Great. Thanks for having me.
Thank you, sir. A huge, huge thank you to Dr. Robert Tanguay for being part of this today. And also, more importantly, to all of our listeners and for the viewers who were with us on our inaugural podcast. This is Painful Conversations, and I really hope in some small way we can change the way we talk about pain.